City Club is pleased to present this program on health care, and we are especially pleased to see the interest that has been generated by this program. It is an important topic for the City Club of Portland, and we're pleased to see the response. In the Forward to Healthcare in Transition, Directions for the Future by Ann Summers, Dr. Edwin Crosby states that, quote, "At no time in the history of the United States has there been greater need for informed opinion on the delivery of health care. The decision on the organization and financing of health services that must be made today will affect us all for years to come. Mounting complexities and inequities, rising costs, and disparities in quality and distribution have posed problems that confront citizens in every walk of life." That book was published in 1971. Indeed, it was probably in the early 70s that the healthcare revolution was developing. The stakes include the fate of a multi-million-dollar industry, as well as the health of the populace. Employers who were turning over funds to insurance companies for employee health plans are now holding on to those funds and at the same time demanding cost containments. Consumers are asking questions about health problems, costs, and alternative treatments, and if they do not get the right answers, they go on to the next health provider. The federal government has set the number of days Medicare patients may stay in hospitals for each diagnosis. And Portland is in the middle of this struggle. We are one of the most competitive healthcare markets in the country. Today we have asked Jeff Goldsmith, who has spent the last year studying the Portland health scene, to give us a report on the national picture and his results of the Portland work. Dr. Goldsmith is a health economist, a native of Portland, Oregon. Jeff graduated from Reed College and earned his doctorate in sociology from the University of Chicago. He has written a book entitled, "Can Hospitals Survive?" That was published in 1981. Dr. Goldsmith was on the staff of Governor Daniel Walker's of Illinois as a budget analyst between 1973 and 75. He worked for the University of Chicago Medical Center from 1975 to 1982, directing the health planning and regulatory affairs of the institution. Currently, Jeff is the president of Health Futures Incorporated and technical advisor to Ernst Whinney, Chicago. It is with a great deal of privilege, having worked with Jeff as a member of the Providence Board of Directors, to have him back to speak to the City Club. Please welcome Jeff Goldsmith.
Thank you, Orcelia, very much, and good afternoon to all of you. This forum has a tremendous amount of memories for me, one of the most vivid of which was staying up late in the evening to listen to a tape rebroadcast of my father's talk to this forum in 1961 on the subject of welfare reform. My uncle John Goldsmith also addressed the Portland City Club, and I was one of the fortunate individuals to be in the audience in 1968 for what was then, I think, a pivotal event in Oregon's political history, the Morse-Packwood debate, where I watched my boyhood idol Wayne Morse fall from grace. Oh, it is a distinct honor to be here with you all, and I hope we can follow in those illustrious footsteps. Orcelia mentioned in her introduction my academic background, something I don't make a great deal of, since carrying a doctorate in sociology into the business world is sort of a humbling experience. You really do have to try harder. I don't know how many of you have followed my discipline, but my colleagues in sociology got into considerable trouble in the 1960s by persuading Lyndon Johnson that if he just gave them a bunch of money and set up a federal agency, they could end poverty. It was a very gullible decade, and as you might expect, retribution came quickly. This is a true story. When Lyndon Johnson discovered that the Office of Economic Opportunity had given a $70,000 grant to the Blackstone Rangers street gang on the south side of Chicago that they had used to purchase automatic weapons for pacifying the south side. Mr. Johnson flew into one of his famous tirades and was heard to remark that the OEO was being run by kooks and sociologists. Bracketing us neatly, we could never understand how the economists got away with it for as long as they did. It was obvious to us that they could not foretell the future of our economy any more we could the social system, but yet there was a Nobel Prize in economics, and every corporation had to have an economist, and we were all sort of chuckling in our beer in the late 1970s when finally the economy went in one direction and all the economists went in another. That maybe they were coming down to join us all in the gutter. And we got conclusive evidence of this when we heard a distinguished urban economist, Anthony Downs of the Brookings Institution, describe an economist as a person who liked to work with numbers, but who lacked the people skills to be an accountant. Or that famous philosopher, George Meany, who described economics as the only discipline in which it was possible to achieve worldwide eminence without ever having been right. So, we all, I think, have a lot to be humble about in thinking about the future. During the 1970s, it was fashionable for people who began speeches about health care to point with alarm to the rising percentage of our gross national product devoted to healthcare spending. That rising percentage of GNP was a symbol to many of a healthcare system run amok, a system dominated by providers of care in which patients were unable to play a significant role as consumers, and with new technologies making their way into that healthcare system and an aging population, that the costs of healthcare services would inevitably soar out of sight, bankrupting our society and requiring the rationing of health services. Well, now by the early 1980s, the middle 1980s, we're confronting the reality that whatever apocalypse was supposed to happen when the percentage of gross national product reached a certain level hasn't happened yet. And I'd like to begin by showing you some slides about what we think is going on. In fact, by the end of 1985, we had experienced the fourth consecutive year of essentially level percentage of gross national product devoted to health care. In fact, during 1985, the percentage of GNP devoted to healthcare was lower than it was 2 years earlier. So for 4 years in a row, the percentage of our national economy's resources devoted to healthcare really hasn't grown at all. Well, what happened? Well, we're going to explain to you what we think happened and suggest in the process that perhaps the popular assumptions we accepted about how our healthcare system works were really wrong. And maybe if we can discover how it does work and what set of assumptions seem valid that might help explain this extraordinary phenomenon, maybe we can help control our destiny in healthcare in our country a little more effectively. Let's look at the various parts of the generally accepted propositions about how our healthcare system works. One of those propositions was that providers of healthcare essentially controlled our healthcare system by dictating the terms of payment for healthcare services. Through fee-for-service-based payment of physicians earned more the more they did to patients. And through reimbursement of hospitals on the basis of costs incurred, hospitals were paid more the more they did. So you certainly had a system that was biased in the direction of growth. But the first indications that perhaps the payment system wasn't necessarily completely helpless in relating to providers of care came during 1982 from, of all places, California. In 1982, the state Medicaid agency decided to put Medicaid hospital services for the indigent in California out to bid. I remember sitting in my office on the south side of Chicago at the University of Chicago, surrounded by 1 million poor people, and just about falling off my chair. Now, who would bid to render care to the poor, a population for whom no one had been competing prior? Well, we learned something interesting, perhaps about California or perhaps about providers of care in general, and that 3/4 of the hospitals in the state of California bid for Medicaid contract. Some of them gave up discounts as high as $700 a day, discounts of as much as $700 a day to continue caring for the poor. They were rewarded by a 21% decline in hospital days under the program. None of them made it up on the volume. But the idea that a state Medicaid agency could exert significant influence in the marketplace was a signal to other payers for care. We are taught in the University of Chicago Business School that prices are a signal to the market. And what California hospitals signaled in response to Medi-Cal contracting and subsequently contracting with Blue Cross, the signal that providers sent to payers was something like, "We're scared to death and we don't know what we're doing." A very bad signal to send to an increasingly frustrated group of payers for care. During 1982 and 1983, the nation's Congress embarked on historic reforms in the way in which hospitals and physicians are paid for rendering services to the nation's elderly. And I think in the process awoke to a recognition that if you're buying 40% of someone's product, as indeed the federal government was of hospitals, you were in a position to dictate to them what it cost and how that service was going to be organized rather than the other way around. And that's exactly what Congress did with the imposition of prospective payment for Medicare services. Even though no one expected prospective payment to have a significant influence on the cost of the Medicare program, the experience has been dramatic. The length of stay for Medicare patients under the first 2 years of prospective payment has dropped by almost 2 full days, and the rate of increase in Medicare spending for hospital services is just about the rate of inflation now, not triple or quadruple the rate of inflation it obtained in years earlier. But what has been going on the public side of our payment system has paled by comparison to what has been taking place among our nation's employers. And I think we'll look back on the 1981-82 recession as a turning point in the nation's employers' attitude towards the health benefit. Significant changes began being made during that 1981-82 recession that permanently altered the structure of our health benefits system, which pays for health services for more than 130 million people. The first major change was a sharp increase in the willingness of employers to ask employees to share the cost of health care. The growth in deductibles and co-insurance for hospital services was very sharp indeed during that 1982 to 84 period, as employers began implicating patients in the cost of health care delivered to them. Patients began being compelled to take more and more of their own money, not just their employer's money, to the doctor. And if in a quiet moment of self-reflection you would probably agree that you tend to spend your own money a little more carefully than you spend someone else's. In addition to the growth in patient cost sharing, employers began redesigning their benefits to place the physician's use of the hospital under increased surveillance. During this period of time, an increasing number of the nation's employers required second surgical opinion programs, not merely paid for them, but required them as a condition of paying for the surgical bill. An increasing percentage of hospital admissions are now under what is called pre-admission review, which is where it isn't enough for the patient's physician to say, "I want to admit you to the hospital." Someone else has to agree that that admission is medically necessary before the bill will be paid. In addition to putting the patient at economic risk and hedging the physician's freedom to admit the patient to the hospital, the nation's employers became believers in alternative delivery systems. And during the 1984 and 85 years, we saw successive 20% plus increases in health maintenance organization enrollment in the United States, as an increasing number of employers offered alternative delivery system options to their employees as a vehicle for attempting to contain the cost of health care services. I don't believe that it is entirely coincidental that during this period of significant change in the health benefits structure, we saw the first significant downturn in hospital admissions of the under 65 population during the post-war period, a decline that has continued apace and has actually deepened during 1985 and part of 86 in most of the communities in which I've been working. What does all of this mean? The changes in the philosophy of paying physicians and hospitals on the part of government agencies and employers. Well, to me it means that economic power has begun shifting from the people who provide care to the people who pay for it. And rather than being passive conduits for the decisions made by physicians and hospital managers, those people who pay the bill are beginning to exert a significant amount of economic leverage over how their dollars are spent. And in the process, a significant change in our health economy has taken place. The era of provider-dominated payment systems is coming rapidly to an end. Exit providers chased by a bear. What about the patient's role in the healthcare system? Well, the conventional wisdom about the patient was that the patient was pretty much helpless in the hands of their doctor because they didn't know what was wrong with them, and they really couldn't evaluate the appropriateness of the decisions that physicians made in managing their care. The patient was essentially a passive pawn in this large medical game. One famous health services analyst referred to the patient's role in the healthcare system as that of the breathing brick, meaning that the job of the patient was just to lie there and let things be done to him or her that presumably generated revenues for providers of care. Of course, when the patient stopped breathing, the revenues stopped coming, so you had to keep the patient breathing, but little more. Well, one of the things that I do for a living is interview physicians. I've interviewed over 500 of them in a dozen different communities in the country. And the composite portrait of their patients that is emerging from those interviews is very different from the conventional wisdom about the helpless passive patient. Physicians tell me that their patients are becoming increasingly vigilant and demanding in their relationship to their physicians. That when a woman comes to a doctor today, she's likely to bring a typed list of exactly how the experience is supposed to go. She wants to have a baby. There's a page and a half of specifications on what's going to happen. You know, is there videotape in the room? Do we have jacuzzis? And if the doctor is not willing or philosophically attuned to supporting the woman's needs, the woman leaves and will find another physician. I think that the impact of the consumer movement and the women's movement and a growing sophistication of our U.S. population about matters medical has begun righting this perhaps imbalance in power between doctors and patients in a very significant way. As the patient is becoming enfranchised economically in the healthcare decision through patient cost sharing, the patient has a real stake in more effective medical decision-making. Patients are becoming less and less bashful in their relationships to their physicians, and there's an increasing amount of tension in that relationship as a result. What about the physician's role in the healthcare system? Well, the conventional wisdom here was that the physician was virtually omnipotent economically and politically. There was a theory in healthcare economics that a physician could set a target income, that is, decide how much money they wanted to make. And if the patients didn't show up in sufficient amounts to justify that income, well, they just raised their rates until the income emerged. Or if that didn't do, well, then you just do more to the patient until you'd made your nut. I mean, some of you think I'm kidding, but I'm serious. That was a prevailing view of how physicians functioned. One that, based on my working knowledge of physicians, I emphatically reject. It's not clear to me that physicians are economic men. There are a lot easier ways to make a living than practicing medicine. I can think of at least 5, selling commodities, packaging real estate deals, robbing banks. I mean, take my word for it, consulting. You know, there's a lot of easier ways to make a living than getting up in the middle of the night to go down and deliver somebody's baby. But even if it were true, that vicious caricature of the doctor as economic man, it's difficult to abuse a patient who never shows up in your office. And over the last 10-plus years, the nation's physicians have experienced a sharp fall-off in their office visit volume that continued during 1984 and 1985. Some of you may have seen that marvelous cartoon, Doctor, the patient will see you now. But the fact is that patients are an increasingly scarce supply, a function of the fact that the number of office visits to physicians on the part of a typical family is falling, and in addition the fact that the number of physicians in the country per population has been growing sharply. By the end of the century, the rest of the country's physician supply conditions will look a lot like Portland's. In other words, there will be physicians literally on every corner. There will be no shortage of physicians. People will be doing house calls. They will be rushing over to see you. When you have a medical problem, people will be answering their phone calls because there will be a substantially underemployed, especially cadre in our country. I don't know how many of you can see this cartoon, Frank's Neurosurgery, $200, the works, no waiting. The fact is that our nation's physicians have experienced a very sharp deterioration in their market position in the last few years. The response to this sharp turn in their economic fortunes and the erosion of what has been traditionally a very high level of respect for their decision-making has produced physician reactions bordering on panic in many of the physician communities that I have visited. However, out of the din of dashed hopes and confounding of rising expectations have come an increasing chorus of constructive voices for change within the physician community. In virtually every community I have visited, physicians are working to organize alternative delivery systems and cost containment vehicles that are working towards a more conservative use of health resources. And perhaps the most vivid single example of a changing physician attitude could be found in the September 6th issue of the Journal of the American Medical Association, in which a prominent physician argued to her colleagues in the AMA's own journal that there was so much inappropriate utilization of health services in the United States that until physicians had achieved a more conservative use of health resources, it was not only premature but inappropriate for physicians to participate in the rationing of needed care. This statement was made by a physician named Marcia Angel, deputy editor of the New England Journal of Medicine, and contained a lot of persuasive evidence of excessive clinical testing in hospitals, evidence of excessive and medically inappropriate aggressive treatment of the terminally ill patient, and evidence of substantial variation in the incidence of elective procedures and surgery among varying regions of the country that did not appear to have any underlying basis of clinical reality. I brought the most inflammatory example with me this afternoon, and that is the nearly threefold variation in the incidence of such elective procedures as hysterectomies and cesarean sections among regions of the country. It is clearly a lot safer to be a woman in New England than it is in the southwestern part of the United States. And I cannot find a credible medical authority that believes there is any underlying clinical or epidemiological reason why there is so much variation in the incidence of these painful and expensive procedures. Now, I hear increasing voices of responsiveness and responsibility among the nation's physicians, suggesting that they understand full well the importance of putting their clinical house in order and in living within this society's means. What about the hospital? Well, the conventional wisdom about the hospital was that the demand for hospital services was virtually limitless. That if you build a hospital bed, patients would magically appear in it, whether they were sick or not. There was an artesian well or something. If you build a hospital, patients would appear in it. In fact, we developed a whole regulatory system called Certificate of Need, premised around the idea that if you just prevented hospitals from building beds, we wouldn't have so much hospital utilization. It was a spectacular failure, this program, one that I've likened to getting a person to restrict his weight by preventing him from buying new suits or restricting the size of the clothing that he can wear. Didn't really affect the metabolism at all, but it, produced a kind of a shabby, overgrown look that maybe embarrassed you from going out in public and eating a lot. Well, I don't know where the people that argued that the demand for hospital care was limitless, but you certainly don't need a doctorate in health economics to recognize that that is not a growth curve, okay? Growth curves go up to the right. That's the demand curve for inpatient hospital services in the United States over the last 10 years. And by the end of 1985, the nation's hospitals delivered fewer days of inpatient care than they did 10 years earlier, even though hospitals had much more medical technology and a much older elderly population to treat. Hospital utilization has fallen dramatically in the last 5 years. In fact, in some regions of the country, like the upper Midwest and the east south central region of the United States, we've seen 30 to 40% reductions in per capita consumption of hospital services as payers for care in those communities began ratcheting down on how health services were provided. I have been emboldened here. I'm told by my friends at the University of Chicago that if you want to win a Nobel Prize, you never make specific numerical predictions. And if you are so moved, you never give a date by which they're supposed to come true, because then you'll be proven wrong and the Nobel Committee won't. Well, sociologists are never going to get a Nobel Prize, so to heck with it. I think that if the demand for inpatient services moderates, from the pace of decline that we've seen in the last few years, we're going to produce an inpatient hospital census in the United States roughly half that by the end of the century what it was in 1975. I've shown these numbers to some of my colleagues and friends in New York City, where inpatient hospital use rates are substantially higher than the national average and been greeted by a lot of shocked silence and disbelief. I think people were back working on their resumes or something. Well, what's going on here? Why should the demand for hospital services be falling when it was supposed to rise? Well, I suggest that the reason is that hospitals are the highest cost provider of services in an increasingly cost-conscious marketplace. And just like the rising price of oil encouraged our nation's industries to find substitute fuels and to conserve the use of energy, the rising price of hospital care has encouraged the search for cost-effective substitutes for hospital care and a conservation of hospital days through mechanisms like the ones we have been discussing earlier. And what's the bottom line from all of these perhaps disconnected musings? Well, that maybe there really is a market for health services after all, and that this supposedly exempt sector of our economy may behave in ways that seem very familiar to us, that there is a relationship between supply and demand, and between the price of services and the demand for them in the future. Now, some of you may have wondered in the title of my talk, the Healthcare Revolution Report from the Front, where the front was. Well, it's interesting because you're in it. It's here in Portland, Oregon. I believe that the Portland healthcare marketplace stands as impressive evidence in support of the idea that a competitive health economy can be healthy for the general population. I would assert, as a person who's studied at least a dozen different healthcare markets in the United States in detail, that Portland is the most competitive metropolitan healthcare market in the country. It has one of the highest ratios of physicians to population in the United States. Its HMO penetration, the percentage of Portlanders enrolled in HMOs, is more than twice the national average. And there's only one community east of the West Coast that has a higher percentage of patients in HMOs, and that is Minneapolis. Inpatient hospital utilization in Portland is more than 1/3 less than the national average and is 1/2 on a per capita basis. Hospital utilization in Pittsburgh and in other eastern cities, a statistic that stuns my friends in the East. And that utilization rate is still falling. Our projections suggest that by the end of this decade, the average length of stay in Portland hospitals, including the seriously ill patients that come into the area from outside for heart surgery, trauma care, etc., that the average length of stay in Portland hospitals will drop below 5 days by the end of this decade, and that inpatient hospital utilization in Portland will probably fall to a level that many people only believed you could achieve inside health maintenance organizations. And yet my subjective perception, on the basis of interviewing dozens and dozens of physicians in this community and being able to put what they do in a comparative context, would suggest that the quality of health care services available to this community is exceptionally high as anywhere I've worked. I think you are blessed with a conservative physician community, and I mean conservative in the old-fashioned positive sense of the term conservative. You don't see a lot of physicians driving around in Rolls Royces or Lamborghinis in Portland, and your physicians among you do not appear to have been driven to the same extent as their colleagues in California and the East by aspirations to retiring at the age of 40 with a pile of money put aside. The cost of health care in Portland is, relatively speaking, a bargain. I have taken the cost per inpatient admission of 2 of your prominent non-university, is that backward? No, it's not. 2 of your prominent non-university referral centers, and I've compared it to the leading referral centers in Cleveland, Ohio, Pittsburgh, and Los Angeles. And as you can see, the cost per inpatient admission in your 2 distinguished facilities is anywhere from 20 to 40% less than the cost per admission in facilities that I wish I could name for you because they are prominently recognized as the distinguished referral institutions in the country. I would suggest to you that Portland is a distinguished example of the proposition that a competitive health economy can produce superior results, and you all are spoiled, I think, really rotten by the quality of health care you have available to you here in this community. Having said that, I must remind you that I no longer work for anyone in this room, and those remarks are completely unsolicited. Now, we do have some unfinished business in our health care system nationally. The two most prominent pieces of unfinished business I can think of are providing adequate access to health care services for the more than 30 million people in our country that still have no health insurance, and as well, and perhaps a more serious problem, providing an adequate framework for providing chronic care and rehabilitative and restorative services to people. We haven't really focused on either of these problems as a society, but I believe our ability to solve the problems will be a function of our attitude towards our ability to solve them. I do not believe they're intractable. It's not clear to me that competition or a competitive marketplace is going to be sufficient to bring solutions to them about, but that if we direct our attention to solving these problems, we can devise the mechanisms for financing care to this population and try and create a humane framework for providing chronic care services without completely uprooting this system that we already have. I am at least one individual that is growing tired of hearing how we are in the U.S. somehow morally inferior to those European countries that long ago nationalized their health care systems and encased them in bureaucracies. If these systems are so effective, why do Americans dread falling ill in Europe? Why is it possible to purchase air ambulance insurance to air evac people back to the United States for care if these systems have achieved an adequate standard of health care services for their people? The fact is that these European systems have hit the wall economically, are experiencing increasing labor difficulties and financial stringencies, and are, in the judgment of a lot of observers, beginning to erode the quality of care available to their populations. Why should we seek to emulate these societies and their bureaucratic solutions to our health care problems when we have within our grasp the tools and mechanisms to create a health care system that both meets our expectations and that we can afford? Americans don't like standing in queues. They don't like being told in a paternalistic fashion what's good for them by some higher authority. Americans like making choices. They like to shop around. They like using their intelligence and critical judgment to improve the quality of their lives. And they like our health care system. And for good reason, it's by a goodly stretch the finest in the world. Regulatory approaches to containing health care spending failed, precisely because they failed to alter in any significant way the behavior of doctors and patients in the use of our health care system. Regulators relied on indirect mechanisms of forcing institutions to behave in certain ways rather than altering the behavior of the people that use those institutions. What competition in healthcare has done is that it has compelled all of the actors in our healthcare system to come to the table with a greater responsibility for the cost of healthcare services. A rearrangement of risk and economic responsibility for healthcare cost is underway in the United States. Physicians, hospital managements and boards, patients, employers, and insurers all have a piece of this problem. In a democracy, the larger the circle of individuals committed to solving a problem, the more likely it is that we will solve it. And I believe that if we examine the experience that we've had in this country in the last 5 years, we will discover that we have the tools to take the $400 billion that we're spending on health care in the United States and stretch those dollars to meet the substantial unmet needs that remain. I believe that if we have confidence and faith in our ability and use those tools effectively, we'll have a much better health care system in the year 1995 than we do today. Thank you very much.
Thank you, Jeff. It sounds like we've evolved from breathing bricks to inform consumers, and in that spirit, we'll start the question and answer period. Tom Higgins has the privilege of the first question.
Thank you. The Wall Street Journal a couple of weeks ago had a lengthy article about HMOs, and the thrust of which was that perhaps the bloom might be off the rose. They focused on Portland, Oregon, and quoted Jeff extensively in his observations of Portland and where HMOs might be going. I wonder if you wouldn't mind elaborating just a little bit on that subject, particularly with respect to the question, number one, how much real price competition do you think there is likely to continue to be among HMOs in Portland, given the already existing record with respect to utilization? And number two, understanding, of course, that you don't have a crystal ball, what do you expect to see in the way of product differentiation as part of that competition between Portland-based HMOs?
Well, that's a tough bunch of questions. I think the thrust of the Wall Street Journal article was in suggesting that in communities where you have very high rates of inpatient hospital use, the HMO has a relatively easy task. HMOs typically experience about 400 days of care per 1,000. If you're operating in a market with 1,300 or 1,400 as the community-wide standard, you've got quite a little margin there to arbitrage and to build in a lower cost product and rate structure to offer to employers. In a community like Portland, there really isn't all that much margin, and that margin is continuing to disappear as the community-wide standards of healthcare services converge on the HMO standards. My sense is that HMOs will be experiencing an enormous amount of margin pressure, that they won't be experiencing the profitability that HMOs have had in other markets, and that it will be increasingly difficult for HMOs to offer a significant price advantage over let us say, an indemnity plan, a non-HMO plan that offers perhaps the same benefits. How are HMOs going to differentiate themselves when the price advantage of being in an HMO has disappeared? Well, one could argue that the comprehensiveness of benefits and the ability better to organize how healthcare services are provided rather than having them sort of purchased a la carte, that the people that are able to offer Portland the best organized package of services, one that works effectively to resolve the patient's problem, that will probably be the winning combination. This has to be the toughest HMO market in the United States. It's certainly been tough enough to keep the big national chains like U.S. Healthcare and MaxiCare out. They know better than to come in here.
Questions are restricted to members of the City Club. There is a microphone that has been set up in the center of the room. Please identify yourselves.
Mr. Goldsmith, you mentioned that healthcare costs are leveling off, hospital costs at least. I think you said something like below the current rate of inflation. Is it?
For the Medicare program.
For the Medicare program. That being the case, why are all the insurance providers, whether current premiums going up?
Well, I think the reason why insurance premiums go up is because people are anticipating future inflation in the rates. They're certainly not going up at 25 or 30% a year like they were a couple of years ago. We're hearing 5 to 10% rate quotes now. But I think as insurers are beginning to realize that they may not have to settle for, quote, breaking even in writing health insurance, that if they push hard enough on healthcare providers demanding economic concessions, that they can probably make money writing health insurance. Well, I think rates for health insurance are still going up, but they're certainly not going up at the rate they have been in the past few years.
Yes, next question.
Dr. Ralph Crawshaw, City Club member, Project Director for Oregon Health Decisions. I'd like you to speak a little bit about the possibility of these savings in days and dollars coming out of the quality of care. And I would cite, for example, that the psychiatric world is about 1 decade ahead of facing the problem of expensive hospitalization, and that in the 70s we implemented a program called deinstitutionalization, in which we took all the same curves you showed here and we put them all down real low. We did this by moving into the community sick people where they are now residing in Fred Meyer's day care hospital situations and filling our jails. Now, specifically, right now in this state, it is coverage for a child needing psychiatric hospital only for 2 weeks. From that point on, there is no coverage whatever, and the quality of care for some children is severely neglected because of the very careful economic approach to medicine. Thank you.
I think it is difficult to argue credibly that there is a correlation between cost and quality in healthcare services. In fact, one can argue that hospitals are dangerous places that there are places that unless you can find alternative methods, it would be better for people not to be. People come into hospitals and 3% of them acquire nosocomial infections, infections related not to the original condition that brought them in, but to the hospital environment itself. It's not clear to me that citizens in this community that use half as much health care hospital services as citizens in Pittsburgh or New York aren't actually healthier than their opposite numbers in those communities. So I'm not prepared to accept the equation that more health care equals healthier people, because I'm not sure it's supported by the numbers.
I'm Dr. Donald Holden, a physician and surgeon. You paint a picture, Dr. Goldsmith, of great optimism down the future, but I wonder what you would have to say about the possibility of increasing failures and going out of business aspects of hospitals across the country, and the impact this will have on the charts that you have made, and also the problem of rising malpractice costs to physicians, which are now driving physicians out of practice, and what impact this will have on your projected equations.
Two different questions. On the question of hospitals going out of business, it's pretty clear to me that we've got enough hospital beds in the country to treat a population half again the size of our current U.S. population. And just as I'm not sure it's our society's business to be propping up steel mills that are producing a product that no one is willing to buy, that it makes sense for us to support hospital capacity well in excess of what our population needs. So I think it would not be entirely inappropriate if a significant number of hospitals in our country closed their doors. As to the second question, I am very concerned, and I think nearly everyone else in healthcare is, about the rising rates of malpractice insurance. It is an intolerable situation when the society is trying to control healthcare costs that malpractice insurance rates are rising at the rate that they are. My personal feeling, I'm not sure my father, who's an attorney, is going to agree with this, is that our tort liability system needs seriously to be re-examined, and that if we're asking people to take a piece of the healthcare cost problem, maybe one of the groups that will have to take a piece of it is the nation's attorneys.
And I would ask that you try to keep your questions brief so we'll get everybody's question in. Next question.
Thank you. Patrick Easton, City Club member. We've recently read, we heard the Wall Street Journal quoted earlier, that the Graham-Rudman will take effect, I believe, September of this year if President Reagan and his budget is not approved. I'd like to know your feelings across the board. Now, we know that the sacred cow, or the sacred thing that we need to protect most, is our defense budget. If Graham-Rudman is put into effect, and we already know that our president has said that he will not increase taxes in 1986, what effect will that have on Medicare, which is already in a great deal of trouble in our country?
Well, I think the Medicare program has a limited exemption from Graham-Rudman. I think there's a 1 or 2% restriction on the amount of funds that can be cut from the Medicare program. But even at that level, you have a population of eligibles that is still growing and pressing on Medicare limits. There's no question in my mind but that if Graham-Rudman is permitted to go into effect, if it's proven to be constitutional and everything else, that there will be significant stringency in the nation's hospitals. The prospective payment rates paid to hospitals will not increase. I mean, people will start getting used to the numbers they're hearing because they're not going to go up. And providers of care will have to live with and eat the cost of inflation and growing intensity of illness of the patients that they are treating. So I think that probably the sector of the health economy that will be hit the hardest are the nation's teaching hospitals. They will lose indirect cost allowances for their research programs. They will lose direct and indirect support for medical education. I think the teaching hospitals will probably be the hardest hit. There will be a significant impact from Graham-Rudman on the nation's hospitals.
Gretchen Kafori, Bleeding Heart Liberal. I was distressed by the dismissal of the 30 million people that don't have access to care, because a lot of us here spend majority of our time trying to devise ways of providing care to them. And with that, I know that wasn't the subject today, but I'd feel more fulfilled if you could give us a few ideas about what the future holds and maybe mechanisms that we could use to finance the care for those 30 million people.
I hope no one interpreted my remarks to suggest that problem was either dismissed or not a serious one. It is. I think that there are efforts being made now to create state-level pools through taxing health insurance premiums or through taxing hospital stays, to create pools of funds that can be allocated to pay for the cost of indigent care services rendered by hospitals. Of course, those pools omit typically the physicians who provide services to this population. They also omit many chronic care services, which are often as much needed as the acute care services that are perhaps most costly. My nominee as a non-smoker and non-drinker for the appropriate tax base for raising funds for this population is alcohol and tobacco. You know, in this community on a typical day, only 1.5 people or 2 people per 1,000 are in a hospital bed, but perhaps 300 or 400 per 1,000 smoke cigarettes, and who knows how many drink alcohol. So I think, you know, answer to question number one, it is a social responsibility, one which people have been passing back and forth among different levels of government for quite long enough. And number two, in raising the funds from public sources to treat this population effectively, I think we should try to find the broadest tax base that we possibly can to do it in an effective way.
Jane Bloom, member. I would like to follow up on Dr. Crawshaw's question, because I think he was concerned about mainstreaming or bringing psychiatric patients into the community without the community resources to help them. Does this fall into what you said before, or are there other models that we might look at too?
Well, the federal government is unfortunately encouraging hospitals to discharge patients into the community where there are not adequate nursing home beds or, in some cases, home health care programs to support them. So to the extent that we have perhaps not learned from the experience of deinstitutionalization, there is something of a lag in creating the availability of the services to treat people that have been discharged from the hospital sooner. However, I do see signs that there are people in Congress, including your Senator Packwood, that are defending the financing of home health care services during this period of time, and a lot of people that are looking at the adequacy of financing alternative services so that as we move people out of the hospital, there are places for them to go. I don't think any of us wants to repeat the experience that was had in mental health.
Yes.
Poppy Warren, member. When do you think a DRG-type program on the outpatient side will be implemented by the federal government, such as AVGs, and what do you think will be its economic impact?
Well, for the people in the room that don't know what a DRG is a diagnosis-related group. It's one of those marvelous acronyms that pops out of Washington periodically. It's a per admission or per hospital stay basis of paying for hospital services. I don't think the federal government is going to move to pay for outpatient services on a DRG specific basis. Outpatient services are just too complex and diffuse to be captured in a DRG type methodology. A hospital admission is a countable event. You can tell when one has started and when it has stopped. It's very difficult to quantify what a doctor does to a patient during the course of an illness in the same neat way. So I think what we're going to see instead are frozen fee levels and utilization controls exerted by the federal government as a vehicle for restraining that sector of healthcare spending.
Jeff, Kirk Wilson, City Club member. There are two other payment vehicles that are contemplated or are currently in effect, one of which is a Medicare voucher system, which is adamantly opposed by the congressman from East Portland, who's adamantly involved in health affairs, Congressman Wyden. And a second one is a concept known as preferred provider organizations, PPOs. Could you comment on both of those and how they affect the healthcare system?
As to the first question, the idea of a voucher system, the idea that you'd give elderly people a check every year of so much money that they would use to purchase health insurance, I think realistically we're 5 years away from doing this. There is already, it's interesting, a semi-voucher program available for elderly people that want to enroll in HMOs. HMO elderly people in this community have the option of enrolling in a health maintenance organization and having all of their Medicare services covered by payments from the federal government to that HMO. And I think the experience here in Portland and other places has been that just the voluntary option of being able to enroll in prepaid plans may be sufficient to move as many as a third of the nation's elderly into them over a 5 or 6 year period. So we may not need to go to a voucher plan to get people to choose alternative methods of insurance. On the other question of a preferred provider organization, well, that's simply an arrangement for negotiating between employers or insurers and providers of care for better rates. I'm not sure that the preferred provider organization is a strong enough cost containment vehicle to be able to compete in that increasingly competitive health insurance marketplace. And I'm not sure just negotiating down the price of services is enough. HMOs control utilization as well as bargaining for price. And I think that's a much stronger basis for having a competitive health insurance product.
Jeff, there is some indication that private insurance carriers may look at DRGs and impose those among their clients, that it won't be just the federal government. Any observations on that?
Well, I don't really see any movement on the part of the federal government towards or on the part of private insurers towards DRG payment either. What private insurers are discovering is that they've got pretty impressive tools for controlling healthcare cost already. They can just flat out say to hospitals and physicians, we're not going to pay for this inpatient admission if it doesn't meet certain standards. They are also able to, even if you've got only 500 or 1,000 employees, there's probably a hospital provider in this marketplace that will make a deal with you for somewhat less expensive care. So it's not clear to me that you'll need to use something as complicated as DRGs, which is really a very complicated methodology, when simpler mechanisms for achieving savings in healthcare benefits are available.
I'd like to ask another question, if I might. As you know, Jeff, there has been quite a wave of mergers and acquisitions among hospitals and in the health insurance industry in the last several years. Some people have suggested that perhaps by the end of this century that there may in fact be remaining in the United States only 8 or 10 large national organizations. Do you agree with that? And if you do disagree, perhaps you could elaborate a little bit on the reasons.
It is difficult to argue in 1985 that healthcare is a concentrated activity economically. I think only that the 7 largest providers of healthcare in the country right now only control about 5% of the total healthcare spending in the U.S. There's only one that has more than 1%, that's HCA, and those of you that have followed the newspapers know that they've sort of paused on the way to 2%. So I think that the forces that encourage the consolidation of the industry are slowing very rapidly. I guess I'd believe that we were going to end up with 8 or 10 healthcare organizations in the country if I really believed there were economies of scale in healthcare delivery. If there are, they're very bashful, because we've looked for them and we really can't find them. I don't think there's a national market for healthcare. I think there are regional markets for healthcare. And since we have several hundred metropolitan areas, I think we will have thousands rather than dozens of healthcare providers in our country for the foreseeable future.
The last question.
I'm Bob Shoemaker, a member of the club. I'm also an attorney, so I'm liable to get myself in trouble with this question.
Well, we're ready for you.
I'd like to bring you back to the malpractice question, which I thought you rather facilely palmed off on lawyers as being the principal villains. I won't excuse them entirely, but I suggest that perhaps juries, in their sympathy for the particular complaint that's before them and the unlimited recovery that they are allowed to award, is the real miscreant here. And I wonder if you have some thought on how to cure that problem so that we can get not only malpractice insurance, but malpractice awards under control.
Well, the state of Indiana, I think, has probably come up with the best system, which is a panel to review the cases that is empowered to make some judgments, a cap on the liability on pain and suffering, and a cap on the awards. It seems to have worked in Indiana, and I think there are a lot of other states that are looking at it. It isn't entirely, attorneys, you're quite right. We have a bizarre system where we're trying to solve a societal problem on a case-by-case basis, and that's a very expensive mechanism indeed. Well, I think that perhaps recognizing that tort liability system may not fit healthcare very well, we'll create special channels for screening out the inappropriate cases, for trying to review the cases that do have merit in a dispassionate way, and capping the economic awards in such a way that there's a reasonable distribution of risk and responsibility for malpractice. It isn't just the lawyers.
We appreciate the fact that Jeff has flown to Portland just to see his family and to speak to City Club, and he will be going back to Chicago for preparing for the Super Bowl party. With that, thank you, Jeff. We are adjourned.